Welcome everybody, wherever you are. I know we're all over the world, so it's morning, afternoon, and evening. Hope all is well. What we're going to do is we're going to talk about QBLISS, the use of the QBLISS technology, and I'm really excited about this. Today, we're going to focus more on how we apply it to periodontal health, and not just talk about how the equipment works research-wise and scientifically, but I'm going to talk a little bit about my personal journey, the challenges that we have in dentistry today, what we see when we use the QBLISS equipment, the visualization we can see both for ourselves and with our patients, the educational benefits, the motivation, and the monitoring then that we can do with our patients. We're going to talk a little bit about the workflow that we use when we use the equipment. I'm going to focus and kind of simplify it a little bit. We'll talk a little bit about the scripting that hygienists can use when they're talking to the patients, and the doctors can also use. And then I'm also going to talk to you all about, I think this is a very exciting time. In having been a dentist for as many decades as I have, I just feel like there's this change in dentistry, which I think is a good thing for all of us, and especially for our patients. So what I want you to understand is, as we go through this, we'll be going through it again fairly quickly, but if you have any questions, please let us know what those questions are. But I really believe that the information that we're going to go through right now can easily change your practice for the better. And when I say for the better, I think it's for the betterment of ourselves as the clinicians, and it's for the betterment of our patients in the treatment they receive. Because think about from the patient's perspective, they come into our offices and we look in their mouth. Well, Mrs. Patient, you have a lot of plaque or biofilm or food between your teeth. You know, you really need to brush and floss these areas better. What does the patient really get out of that, right? We know we see patients every day that have these large wounds, this periodontal disease, but it's kind of like in their pocket. It's an area where they can't see. And that disease is affecting their overall health. They can't see it, they don't understand it, and basically they're in the dark. And so then we pull out our intraoral cameras. So in the US, when I pull up the research, it says about 60% of practices have intraoral cameras, but I don't know where those cameras are, right? They could be in the hygienist's operatory, they could be in the operatories used mostly by the dentist. They could be in all the operatories, but is anybody really using them? So we pull out the intraoral camera and we can take a picture of a tooth and say, look at this image. See right here with all this white stuff, that's biofilm or plaque. That is the bad stuff in your mouth. But again, when we say that, Mrs. Patient, you've got biofilm, you need to brush and floss, do they really see a problem? You know, I would say they don't, because we've been doing this for, hundreds of years, trying to get patients to brush their teeth, to floss their teeth. And periodontal disease is still rampant, right? The majority of us have some type of periodontal disease or gingivitis. And so the effectiveness of what we've been doing in the past doesn't seem to have worked very well. So now we use the equipment that we're talking about this today, and we're talking about the biofluorescence technology, and we use that intraoral image with the special light and filtering that we have. And now we tell the patient, Mrs. Patient, wherever you see red, that is bad. That is the bad bacteria that causes gum disease and causes cavities. And this picture is of the biofilm right by your crown. So the crown's not going to get a cavity in it, but the root or the tooth right between that crown and your gum line can get cavities. And we don't want to have to redo your crown, because that's a large investment of both time and money. So Mrs. Patient looks at this and they see the red glow, and we tell them, if you see red, red is bad. So we go through the same kind of explanation. Anywhere we see the red is bad. And then before we even get to you need to brush and floss, Mrs. Patient is asking you, what do I do? It's a whole different scenario, right? Before, they were completely in the dark. We didn't show them any images. We just told them what was going on. And then the next level up is we show them an image of what's going on with the intraoral camera. But they don't see anything, right? Because the plaque or the calculus is all sort of tooth colored, and they don't really understand. We think they understand because we can see it, but I don't truly think our patients can see. And now we use this technology and we show the patient and explain to them that wherever you see red is bad. The patient looks at this image and it's glowing red. What I'd want you to think about is, would that motivate you to do something? So real quick, I know we did some, in our last program, we did some introductions, but just wanted to kind of introduce the perspective that I have. So I've been in practice now for 39 years. I'm in a private practice. We're in Sacramento, California in the US. So we are in the capital of California. And in our area, it's very insurance driven because our major insurance companies take care of the government workers, and we have the state and federal government workers here. So I practice full time, but because we are not contracted under insurance, everything that we do, we need to build extra value in so our patients value our services, because they may not get the full benefit of their insurance. And then just to put it in perspective, I do my own hygiene. So I did a prophy today. So when needed, I will do the hygiene procedures myself. And so whatever we're talking about today, not only do I see it from a hygienist point of view, and I also see it from the doctor's point of view. So what has changed is today we have to talk about ways to build trust, how to educate our patients, how to motivate them, and how to provide them with better care. But I think a key word here is we have to do that more efficiently. We can't spend all day trying to explain to the patient what biofilm is and the bad that biofilm is going to do. In the old days, when I go back even 30 years, it was a different time. In the US, if you're a patient, a dentist, the patients would come into your practice and probably be with you their whole life. The hygienist that you hired would probably be with you his or her whole career. And so the hygienist would see the patient. They've got this strong relationship. The hygienist would say, hey, I think this tooth's got a really large filling and a crack. I think the doctor's going to come in and probably recommend a crown. The doctor, we'd walk into the operatory, and again, this is a long time patient, and we look at the tooth, and sure enough, large amalgam, decay, cracks in the tooth, and we just tell the patient, okay, you need a crown. And the patient would accept that because they trust us. They've been with us for a long time, and they'd go and schedule. Today, it's a different story. There is no old hygienist, right? A lot of the hygienists are fairly new to the practices because they're rotating in and out. They're moving. The patients are fairly new because no longer do you have patients for their whole lifespan. If their insurance changes in the US, oftentimes they will find a new provider, and time is always short. We don't have the time to do our education with our patients. And so most of us in the back office, your hygienists, your doctors, assistants, we know how to use intraoral cameras and we show the patients things, but again, do the patients really understand or value the images that we show them? So that's why having this color, I think, is so important, because the color really resonates with the patients. Not only is it diagnostic, and we'll talk about that in its own way, but I think having that color there points out to the patients where the bad is and helps them see that. And then what we're going to talk about is that allows us now to step into what I call dentistry 2.0. And that's what I'm really excited about, because again, after having done this for decades and having done all kinds of dental procedures and surgeries, we're always looking for ways to be more conservative, because if you are the patient, how would you want to be treated? And roll that back, because I know there's hygienists watching this, there's dentists watching this. Do you like going to the dentist? And when you go to the dentist, what do you like? Many of us, when we're treated by a colleague, we want conservative treatments, right? And so I think that's the way that if we see dentistry moving, it's moving in the right direction. So when we look at the technology suite that we have to work with, on the left-hand side, we have the LinkedIn's QC. It's a camera. We have the Gray Pen C, which is like the intraoral camera. We've got the LinkedIn's View second from the right, which is like a curing light that with the special goggles, we can see where the biofilm is. And then we have the QScan Plus. We can tie many of those systems together with the LinkedIn's. That really helps us pull in that AI technology so our patients can work with us. And even if we're doing teledentistry, we now have the tools that we'll talk about to help our patients. So one of the things about dentistry is we've been very reactive. We wait for disease, and when disease occurs, we treat the disease. And oftentimes, it's like insurance requires us to do that, right? We can't provide treatment for a patient unless we can prove there's disease, and we can't prove there's disease until interproximal decay is fairly large. And when we treat that, I call that dentistry 1.0. But I think today patients are looking for something different, because all of us know, we have our phones and are watching all the social media. We want to stay healthy. And in order to stay healthy, it's easier if we prevent problems than if we get some illness and then have to get better. And so I think the mindset we have to take as clinicians is, let's be proactive, where we can show the patients where disease is most likely to occur, give them some treatment suggestions to avoid the disease from turning into cavities and gum disease, help treat them minimally invasively, conservatively. And I think that's really where dentistry 2.0 is exciting me, because when I look at dentistry 2.0, what the definition is, I see people saying, well, it's the technology, it's the use of AI. But really, I think it's more of a distinction between dentistry going from a reactive model to one that's more proactive. And I think that's what's so exciting about this technology. So again, this isn't just something that makes everything bad look red. We have to discuss how it turns things red. So the porphyrins, which are a metabolic byproduct from bacteria, is filtered. Well, the light source is a blue light source, 405 nanometers. That is reflected off and filtered so that wherever there's biofilm, it shows up red. And that color then resonates with our patients. It helps us come up with a better diagnosis, because I can actually see things better. I can see the bacteria, and then I can show the patients where that bacteria is. And so they have a better understanding of what's going on in that mouth of theirs. And because of that, any treatment recommendations we make has higher value. Well, so the patient wins, I believe, because we can show them things before it turns into, a more severe sort of disease. And the practice can benefit. And I'm going to show you this towards the end of this presentation, because we can actually increase our revenue. And I think we get better patient retention, because if we can stand out and the patient feels like we are a partner in their health and that preventive aspect of the health, I think that they're going to want to stay with our practice. And then for us, we're working more closely with our patients, so there's less second guessing. Do I have to worry about the patient understanding? Does the patient think I'm over recommending? No, because we're going to work together. They're going to see what I see, and they're going to understand now what they see. Now, the interesting thing about this, because we have people that will listen to these programs and go, well, can I use a disclosing agent? Well, disclosing agent is going to show basically where there's anything sticky, plaque, calculus, whatever. It's going to be very messy. If you've ever done disclosing solution, whether it be drops, tablets, or whatever it may be, you've got to swish it around your mouth and spit it out. And then now your teeth are going to be all kinds of different colors, tricolor if it is. But with this is just light. And so it's very convenient for the patients. And it's not going to just show early plaque. It's going to show the biofilm that's more mature at 3 days or older. So that's what you see in this study, where they were looking at different days of biofilm age. And it wasn't until about day 3 you start to see that red glow. And so we know that, hey, early plaque isn't necessarily a problem, but when that turns into mature biofilm, that's where we have an issue. So when something's young, that's not going to do a lot of harm. But as it matures, like biofilm becomes a more tight-knit community, it's going to be more pathogenic. And that's what we want to show our patients. And just explain to them that, hey, there's local destruction, and that's where you have the bleeding of the gums. When I touch your gums with this little instrument, see that bleeding? That's inflammation. And that chronic inflammation is going to get deeper into where the bone is, and we're going to start to lose bone. Not only that, but that bacteria is going to start to create a systemic response in your body. And we know that research has linked that periodontal disease can be associated with heart disease, diabetes, Alzheimer's, low birth weights in kids. And we don't want what's happening in your mouth to then affect the rest of your body. And you know what? The inflammation in your gums is affecting the rest of your body. We call it the silent signals. Your C-reactive proteins go up. You have more clumping of your red blood cells, and that can lead to a lot of bad things that, hey, we can prevent. So what we explain to our patients is, today with the technology that we have, we can show you the areas that we're concerned about. And then when we use this QBLISS system and you see red areas, those are bad areas, and those are areas that we want to then do something about so that that doesn't progress into further disease. So we have all this the suite of cameras, and not going to go through everything today because of our time limitations, but I just want to point out that when you start to use this equipment, I know whenever we introduce something new in our office, one of the things I worry about is how is it going to be to integrate it and implement it? Is it going to take a lot of time? Is it going to be difficult? And I will tell you, if you're already using the intraoral camera when you see your patients, whether it be for new patient exams, every exam or every hygiene exam, it's not going to take you any longer. But if you're not using intraoral cameras and you start to use the intraoral camera to take images of areas of concern and to show them the red, it's going to take you less than a couple minutes. It's not going to take very long at all. And it's going to be very easy to implement. So this is the QC, the larger camera, and that little area that's kind of cut out in that dome area, that's typically towards the patient's nose because we don't want a lot of ambient light coming in. But I just have it kind of turned the other way so you can see that all we're doing is we're using this camera. It's very light. We're just angling around the patient's mouth to capture the images. And the way you interpret this is the biofilm is going to be, again, more that red area. So that's the area where there's the 3-day-old or older biofilm. If we have kind of a green fluorescence, that's the healthy enamel. And then if we start to pick up areas where there's a loss of fluorescence, that's because we can have demineralization or actual decay. So it's not very hard to even interpret. I know we get a lot of questions. Well, what do the colors mean? Hey, if it's red, it's bad. If it's green, that's good, right? Green means good, red means bad. And if we're starting to lose some of the that green, it's because we have decalcification. So these are the type of images you can get with the QC camera. Put retractors in, have the patient close, and grab this image. Now, when we look at this image, remember where we started. We look at this image and we think, oh, that's bad, right? Because if we look really closely, we see that the teeth aren't very shiny. There's a lot of plaque at the gum line. Some of the basic issues that are going on. We're not going to look at all the exostoses going on. But if we just look at the gums, we can see something. But if you think about you're in the patient's shoes now, if you're looking at these images, and I say, wow, that's really bad. The patient's going to look at that and say, what looks so bad? My teeth are there, right? But now if we color it in and we say, if you see any red, that red is bad. Now that these images take on a whole different meaning. Now the patient looks at that and says, wow, that tooth's almost all covered in red, right? And I go, yep, because that's biofilm. That's the plaque and all the bugs. That's going to cause the gum disease and it's going to weaken your teeth. It's all over the teeth. That's not good. And then if you want to use that camera and have the patient stick their tongue out, or you can pull the tongue out, take a picture, and if their tongue shows up red, I was just talking to a patient about this today. I was just saying in all those nooks and crannies of the tongue, there's a lot of bacteria that can get trapped in there, and it can cause bad breath, but it also just harbors bacteria. That's not a good thing. So what does the QBLISS show? It shows the biofilm, where that bacterial buildup is, that more mature biofilm, 3 days or older, and that can lead to gum disease, bone loss, perimucositis, periimplantitis. But also it's showing early signs of enamel weakening, where the enamel is starting to demineralize and we start to lose that green appearance. And in future programs, we'll talk about how it helps us to find cracks and fractures in teeth, how we can see leakage around margins of bonded restorations or cemented restorations, and some of the other subtle changes that are starting to occur that maybe in a standard dental exam we might miss. So what I think is an important part is this QBLISS reveals tomorrow's problems today. It may not be a big problem today, but if we allow that biofilm to remain where it is, it's going to turn into something bigger. And then the other tool is just the QScan Plus. Again, we've shown this where it's a little handheld, very low-cost way of working with patients. This using retractors here, but you can have the patient use this at home. You can have them use it in the office, so you can start to get into using this technology. But if the patient holds a mirror, they can see the red. They can see the red around the gums, red around the margins, and areas of concern, and we can explain that to the patient. And then we were talking about this before we started this program. We do want to show you how the MCA program will help us track areas over time. So we can look at areas, determine, is there decay in that because of the loss of fluorescence? Is there demineralization that's occurring, and even remineralization of the teeth? So by using this QScan Plus and some of the new AI technology, it really helps us communicate with our patients. They can communicate to us, we can communicate to them. It takes us more into that teledentistry model and opens up all kinds of different possibilities. And again, that's why this technology is just so much more than disclosing solutions. It's just so much more than an intraoral camera. This is really taking us into kind of the next level of care. So as a hygienist, or if I'm doing a hygiene procedure on a patient, one of the things I'm trying to do, especially with a neuro patient, is I want to build trust. I want to make our time together more personal so they feel that connection. And we might start off with a script saying, hey, before we get started, I wanted to share something special that we do here, and it's called QBLISS. It helps us spot early areas of concern before they turn into big problems. The cost of the exam is $25, but it can really prevent problems that can cost thousands of dollars right down the road. So think of it as a small investment that you're making in your smile and just your overall health. And when you think about it, think about this. If a tooth gets a cavity, it's going to be hundreds of dollars to take care of that with a filling. If they get a crown and underneath the margins, we get recurrent decay or secondary decay, we might have to take that crown off and maybe even do a root canal. That's going to be thousands of dollars. If the patient has periodontal disease, and that periodontal disease is contributing to heart disease, and they have to have a bypass or they have a stroke, that's going to cost $1 million, right? So this really is a small investment of time and money. It's like checking your car tires before you take that long trip so you don't break down before you get back from your trip. So I was telling you, I want to talk about how we integrate this, because we're a busy practice. Integrating any new technology is very difficult to do. How do we slow down? How do we learn it? How do we talk to our patients about it? And that's what we're going to be talking about even more and more as we do these monthly programs. The installation and the use of this is really, really easy. Depending on what cameras you get, the intraoral camera just plugs in. The big camera, the QC that you saw me using, just plugs in. And then you just click it. We have Eagle Sauce, so we just hit acquire and we're ready to go. Figure out your fees. Are you going to charge your patients for this service? Or many of you use your intraoral cameras right now. You don't charge for those images, but you don't charge because it helps you find more work. It helps you convert the patients into patients willing to do the fillings and the dental procedures. Train your team. Have your team go through with the cameras, and now they get the wow. Now I can see where I'm missing when I floss, or I can see where my teeth are breaking down, and they can spread that wow. Because if your team can express to the patients, you know what, I didn't think I had gingivitis, or I didn't think I had any gum issues, and then I use this camera and I saw where my gums were red, it's going to help the patient say, okay, let's do that. Use it on all your new patient exams and your hygiene workflow, right? The patients are coming through. Typically, we'll use the camera. I'll look for the red areas, and then I'll clean those areas and go back and show the patients that the red's completely gone. Because one of the things that patients will say is, I don't know if I got as good a clean from you as I did from my last hygienist, right? Well, if I go in there and I show them, well, you've got all this red glow by your gum line, and then I get that all off, and then I show them that red's gone, they think that they got a good cleaning. Because the light helps to see the areas where the bacteria is most active. It doesn't necessarily mean there's disease there yet, but it points out that those are the areas we want to watch to prevent those areas to becoming diseased, right? Gingivitis, periodontitis, or a true cavity. What you have to do also when you get this equipment is commit to use it. So if you install it and you don't use it, you never will get the value. So again, make sure that you use it and then track it. Use it on every patient, and then look back after a week and ask your team, so did it make a difference? And I think it's going to make a difference. When you think about it from a common sense point of view, how would it not make a difference in your practice? And then don't overthink it. Like, I know I have doctors that, again, I mentioned earlier, they worry about the colors that they see. What does it mean? And remember, it's just an aid. It's like your loops or another intraoral camera. It's going to support what you see. It's going to help you see more. But, don't worry. Don't overthink it. It's just as you use it, you'll figure it out. When you present your treatment, put the images up. Like I put this image up and the patient said, oh, that spot right there that I had the blue dot over, we need to do something about that. And the patient said I had to do something about it because they could see the crack. I didn't even get to the point of having to tell the patient what we're going to do yet. So the patients, as you start to use something new, may not get it right away, right? But that's okay. Just keep using it. Be persistent. And sometimes you will find things that are really early and maybe too early to document. And the insurance may not, again, we talked about it earlier, pay for it because you can't document it. But you know what? I would give the patient the choice. Here's an area that I can treat now. And if I treat this area now, we can do it minimally invasively. But insurance may not see the need for it yet, so it may not be covered. So if you want to wait till it turns into disease and it affects your gums or affects the tooth, that's your choice. But what we're trying to do is we're trying to build a high trust practice where we help the patient see, we make our recommendations, and we try to advise them towards minimally invasive treatments. So one of the things that we use PeriProtect trays. We use those trays with remineralization gels. And then I'll use minimally invasive procedures where we use air abrasion. So if I see demineralization on a buccofacial, I'll tell the patient, hey, I'll use air abrasion, which uses really fine particles. We'll clean that area out and then place a tooth-colored filling. Won't even have to numb you up. But the reason why we don't have to numb you up is because we're taking care of it when it's more superficial. When it comes to the PeriProtect trays, why am I recommending those? Because the trays use hydrogen peroxide and push the hydrogen peroxide down into the sulcus to break down the biofilm. And so the stories tie in. Here's the red light. The red color that you see is because of biofilm. That biofilm is causing gum disease, tooth disease, and systemic disease. In order to break that biofilm down, because you're not going to be coming in for cleanings all the time, is that we have to break it down, and we use trays. So what workflow do we use? I use the cameras, show the patient the red, give them a choice. I recommend that we get into the trays, but if you're not ready to do that yet, then let me show you how to clean the teeth better. When you come back, we're going to see if it's better. If it's not, then I recommend that we use these types of trays. If we get to the point where we get into using these trays, the assistants just scan the upper and lower arches. We reappoint the patient back a week or two later. Usually we get the trays back sooner than 2 weeks. And then the patient tries the trays in. We show them a video of how to use it, tell them how often to use it, once, twice, 3 times a day for 15 minutes. And then we follow up with them. When we follow up with them, we can follow up with them using the QBLISS technology and monitor them and motivate them and show them how their gums are getting better, how the biofilm is being broken down, and how their new actions at home are benefiting them. How does it benefit the practice? Well, let's say you are, and this is taking out all the tray therapies that we're talking about, but just treatment acceptance. If you are diagnosing $80,000 a month, and let's say your case acceptance was about 45%, using the camera and the color, increase that by 15%. 15% of the 80,000 would be $12,000. So multiply that by the 12 months. In a year, you would increase your production by $144,000. Now, if you invest in these cameras, which could be $1,000 to $3,000, let's say $3,000, that's a 48x return. So it is really good. So in review, I just look at this as a way of increasing our case acceptance through visual education and trust building. We have to implement the biofluorescence into our workflow because it's going to enhance our patient care. It's going to make our team more efficient because no longer do I have to explain to the patient what they're looking at when they're looking at our intraoral images. All they have to understand is red is bad. Do you see red in that image? Yeah. Okay, that's a bad area. And that's going to allow us to generate new revenue streams within the practice. So it becomes win-win. The patient in the long term is going to save money. We're going to actually do better, and we're going to build that trust. And again, just showing you that 48x return on investment, I think that and the preventive aspect going into this dentistry 2.0 is a reason why we should be doing this. So you can keep doing things the old way, become the clinician, or you could become the clinician that sees more, shows the patients more, and then does more, but before the damage is done. And what I want you to think about is, if you're caring for your family or you're having your dental treatment done, what would you want? And remember, even your family, if they're not dental, our dental colleagues, right? Some of our spouses I know are in the dental field and family, but if they're looking at those white light images, what do they really see? So what we're hoping to do by coming to you on this monthly basis is really build a community that wants to do the very best for their patients using this QBLISS technology, helping our patients see things earlier and then get into treatment earlier. Because I think what's interesting, an interesting way of looking at this is QBLISS makes you visibly different from other practices, because when they go to the other practice, if they ever try to leave your practice and the doctor shows them things with the white light intraoral camera images, the patients are going to be wondering, but where are the bad areas? Because they won't have that red color to go off of. So that's what we're going to be talking about in our future monthly meetings. We're going to be going through more restorative aspects, how it helps us find cracks in teeth, how next month we're going to be looking at how it helps us find decay in teeth, how it helps us prepare our patients for the treatment before we get into areas where we know we have large areas of decay. And even under ceramic restorations, this red light, well, we'll shine the intraoral camera over a ceramic restoration. If we see a red glow coming from underneath there, that typically means that there's a leakage of our cement and bacteria is getting up underneath there. So we have biofilm underneath that restoration. So these are all things that that we'll be covering in future programs. I hope we get to see everybody still attend. All right, so that is a half an hour, pretty quickly done. But I wanted to see, Hannah, is there any questions that we need to answer or anything like that?
Yeah, actually, we do have a couple of questions, so we answered to them while you were giving the lecture. But let's go over for the Mia's question. She asking if you use QBLISS while reflecting the lingual surface with an orthodontic mirror, can you obtain the same image? That's her question in the chatting box.
Yeah, so the question is, if you use the camera, so if you have a mirror and you're going to use the big camera, or the probably not the intraoral camera, because the intraoral camera you could get in to all the nooks and crannies of the mouth. But yeah, if you're using the bigger camera with the mirror, yeah, that will work. And we have the CEO founder, Dr. Yoon here. So Dr. Yoon, if you have anything to add, please do.
Yeah, so image from the Cray Cam Pro is similar with the image from the DSLR, but the quality of the image is a little bit poorer than DSLR. But both of the device has different purpose, right? So DSLR is make that high quality image, but actually our device Cray Cam make actually two images, right? White and actually blue image for screening. So purpose is different. So a dentist can want the screening, and then the dentist use the Cray Cam. Yes, that is my recommendation. Yeah. Also, actually, the mic.
Yes.
I have the question about the a bad breath, the halitosis. So
Yes.
what is the diagnosing the tool or the treatment tool in your clinic? Halitosis.
Yeah. So sorry, what was the
How to actually the diagnosis and treat the halitosis.
Okay. So good question. If the patient has halitosis, then it's typically going to be caused. Well, I think first we have to figure out the cause. Is it caused from the stomach, the gut, or is it caused by what's going on in the mouth? I'm just gonna, for the answer today, I'm going to assume that's coming from the mouth. So If it's coming from the mouth, it's coming from bacteria that's in the mouth, either on the tongue, as we mentioned before, or it could be plaque, bacteria, food that's getting trapped interproximally between the teeth. So we have to adjust that. So treatment would be, many things. You know, the trays I showed before, well, we go through oral hygiene, probably use a tongue scraper, try to clean the tongue, because like I was showing you in that image where that tongue had a lot of redness on the surface. There's a lot of bacteria trapped in all the nooks and crannies. So we explain that to the patient. I think the nice thing about having this technology is we can show the patient how much bacteria there is on the tongue, because if you stick your tongue out, you typically don't see the bacteria. And then, so now if we get the oral hygiene better, so they don't have food trapped between the teeth and their tongue's clean and they still have the halitosis, and again, from an oral etiology, then I would think about the trays I was talking about. Like I have aligners in right now, and I use what we call Perigel. It's 1.7% hydrogen peroxide. So it helps to, again, break down the biofilm and the plaque in the mouth. And those two things seem to work really well. We have some other mouth rinses that you could also have the patient use that are more medicinal. But yeah, I think the big part in the halitosis of an oral etiology for a lot of patients is just lack of good oral hygiene. You know, those are the patients you walk by when you're in a crowd and you smell the periodontal disease, right? And so we need to treat that and help the patient understand what the cause is. And again, I think both the intraoral camera, but that red color that we see is so important, because in that patient, that's a periodontal patient with the halitosis, when we go through the camera, like I didn't show images, but you'll go through the mouth and the gums will just glow everywhere, especially on the lingual side of the mouth. And you show that to the patients and you just show them that, you know, that is bacteria, and that's the bacteria that's causing the bad breath. And, you know, those are the patients that even when you walk in the operatory, you can smell the periodontal disease, and that's what we have to treat.
I usually recommend the QScan Plus for patients. And in the home, even though after they use the tongue scraper, but actually sometimes actually red fluorescence still remain on the tongue after that works. And then actually the next day morning check again. So QScan process sometimes is very, very useful for halitosis patient the self-control.
Yeah, and I think that's a great idea. Yeah, that's a really good idea.
And actually, Mike, how many the dental cleansing per year are typically covered by the insurance in the USA?
Oh, you know, in the US, typically it's going to be 2. And, you know, it's interesting because some insurance companies in the US will allow the patient to have 2 anytime during the year, and some require it be, you know, at least 6 months and a day apart. But typically it's 2. You know, in our office, so we have a lot of patients that are coming in 3 to 4 times a year, and they understand that there's, you know, anything over the 2 that they're going to have to pay for themselves. And, you know, again, that's why I think this dentistry 2.0 is going to really catch on with patients, because there's a lot of patients that will pay for the extra visits because they want the, you know, good periodontal health. You know, I worked on patients today, and I worked on some patients that, you know, have partial dentures or dentures, and they're missing their teeth. And, you know, they all regret that they don't have their teeth. And I always tell them, I tell them, you know, today, that's the message we're trying to carry to our patients, is we're going to do everything we can to help them preserve their teeth, because, you know, as you get older, you know, we all know that wearing dentures, and I don't know if it happens in other countries, but if you are ever taken to a hospital, they'll lose your dentures, and you don't have your dentures, and you sit in the hospital with no teeth. And you know, that's not a good way to have to spend your hospital time. And it seems like every time we have patients that go to hospitals, you know, somehow the hospital staff loses dentures. So we really want them to keep.
In Korea, it'll be the same. Then, but actually, some patients want to more visit to control actually the biofilm. So, and then they asked me, how Dr. Yoon decide actually interval? And then I showed the cray cam image and then compare the previous image and actually the today's image, and much better than actually the, okay, now your interval is 3 months, and then actually the, okay, next one is 4 months later. And then actually the better than actually your interval is become the 6 months, but actually worse, then actually you change the interval from 4 to the 3 months. So
yeah,
it depends on the result of the cray cam image. Very useful for this side the interval. Yeah.
I agree. I think that's the best way to do it. Find a customized interval that works for them and use the technology to show them why that was chosen.
Yeah. Thank you. Thank you for your effort today. Nice lecture.
Oh, thank you everybody for coming on, and I look forward to seeing everybody next month.
Yeah. Anna, yeah.